Good afternoon, everybody. This is Dr. Jayanth. I'm the consultant pediatric neurologist and clinical geneticist at KIMS Kondapur. So today we are going to discuss another interesting session. So this will be on inborn errors of metabolism. So there has already been a session before. Dr. Aravinda has taken a lot of extensively on clinical features and various case scenarios. And you can go through that and we can come back to this presentation as well. We'll continue that presentation and we'll also look at few clinical and radiological aspects which have not been discussed. Good afternoon, everybody. Today we shall be discussing about another interesting session, that is inborn errors of metabolism and the approach of it and the various neurological features and radiological features of this entity. So we'll start with this lecture. This is something I have. Yes. Good afternoon, everybody. Today we shall be discussing on inborn errors of metabolism. So there was a previous session on this by Dr. Aravinda, so it's sort of continuation for that. We'll also quickly go through some clinical presentations and the newer aspects of IEMs and the management, the current updates of the investigations of inborn errors of metabolism. So we shall be discussing this topic in these headings, and we'll just look at the whole history of the IEMs, the odyssey of IEMs, the origin of various inborn errors of metabolism, previously called metabolic disorders. So the preferred term now is inborn errors of metabolism, and the basic principles of various inborn errors of metabolism, clinical handles in IEMs, a few neuroradiological signatures, and a few aspects of management. So, So we'll look into the history of inborn errors of metabolism. To begin with, so it all began somewhere in 1908. This was the first time where inborn errors was actually identified and clinically noticed. So this is an English pediatrician and a scientist, Dr. Archibald Garrod, in 1908. He was the first one who actually came up with the concept of inborn errors of metabolism, and he identified diapers of few babies being blackened because of some abnormality, and these children also had some developmental issues. So, alkaptonuria was the first one which was identified, which paved path for identifying other metabolisms and other disorders of inborn errors. So, these Archibald Garrods, and I mean, this is the landmark where all the inborn errors actually started. So you must have heard about this Garrot's hypothesis is extremely important, and all the other hypotheses like solid bread hypothesis, everything actually roots from this hypothesis. So he was the first person who came up with this concept that so there is a metabolite which actually gets it's so let's assume that A is one metabolite and it is supposed to be converted to B and B is supposed to be converted to C. So there is an enzyme or a cofactor which is deficient, which converts B to C by a genetic mechanism which causes gene failure and eventually the loss of that enzyme. So there are two things which can happen. The C is not going to be produced. So you're going to have a deficiency of the product C. And the another consequence is that you have accumulation of B. So this accumulation of B can have other consequences like this material can be converted into another pathway. So you have a toxic metabolite which is proximally getting accumulated. And the second thing is you also have deficiency of the ultimate product, that is product deficiency. So you can have consequences of both of these events. So we'll discuss what exactly happens with each consequence. So after this is Dr. Asbjørn Folling. He's a Norwegian doctor who came up with the concept of another inborn error of metabolism when he actually saw patients. So he had a patient who was around 2 years and he had intellectual disability. And that family went on having another child who also had a similar sort of inborn error and had the same intellectual disability. So he thought that there is some genetic root cause to all this sort of intellectual disability. And he thought that it was probably a metabolic disorder. So he was the first person who actually identified phenylketonuria. So he identified specific set of developmental issues along with the blonde baby. So he had two blonde babies with developmental issues. So he was the first one who identified phenylketonuria. Then later on, somewhere in 1950s, Dr. Horst Bickel, so he was a pioneer in treating phenylketonuria. So phenylketonuria was actually treated with this dietary restriction of phenylalanine rich foods. So this concept came with this doctor from England, that is Dr. Horst Bickel. And later on, Dr. Robert Guthrie was the first person who actually came with the concept of newborn screening program. And he also coined the term Guthrie's test. So this was a test to identify various metabolites in urine. So this was somewhere in 1960s. So before this, we had no clue about all the IEMs which existed for a lot of time. So then in late after like 1950s, that is in 1955. So this was the first machine which was introduced in helping diagnosing inborn errors of metabolism. This is the machine of GCMS and TMS, which was first introduced in the concept of crime investigation, the murder investigation, and identifying the particles over the murder weapon. So it was later on this concept came to medical sciences. So this is GCMS TMS machine, and this has two aspects of it. One is tandem mass spectroscopy, and other is gas chromatography. So there, the combination is called GCMS and TMS. So then came a game-changing discovery by Dr. Frederick Sanger. So he was the first person who actually sequenced the genome. So then the whole sequencing was named after him. So Sanger sequencing actually takes a lot of time to sequence even a small piece of gene to completely sequence one whole genome of that person. So it's going to take years and years. So this was the first concept of genome sequencing. So this was done by Dr. Frederick Sanger. So then the name of Sanger sequencing came by. So this was in 1960s. So then what we do currently is next generation sequencing, that is NGS. So this came late after 2000. So somewhere in 2005 and 2009, they started using this in the clinical practice in 2009. So this is NGS-based technology. So this is the next generation sequencing. So after this came the concept of omics revolution. So this is genomics. So we'll talk about omics revolution. So we do a lot of genomic sequencing these days. So what the first sequencing was done in 1975 was Sanger sequencing, which is called the first generation sequencing. What we currently do is the second generation sequencing, which is also called the next generation sequencing. So this is by Pyro Illumina sequencing. What we are looking ahead, and it's now available in various countries, this is third generation sequencing. So this is by this company called PacBio and Oxford Nanopore sequencing. So this has a little advanced technology. This is the future of genetics, that is third generation sequencing. So it all started with Sanger, then second generation is introduced by McCook, and the third one is a combination of PacBio company and Oxford Nanopore sequencing. So normally whole exome sequencing takes around, the TAT is around, the turnaround time will be around somewhere between 3 to 4 weeks. And now we have a concept of a rapid exome sequencing, which usually takes around 5 to 10 days. But there are a few countries and machines wherein, you have molecular genetics available around the clock, so which can be done within 2 days. So the total TAT is less than 48 hours, that is around 37.4 hours. So you can have the whole genome sequencing of that particular patient, especially useful for, intensive care children in inborn errors of metabolism and few cardiac conditions as well. So coming to 2022, so this actually was done in Stanford Medicine. So they actually got the Guinness World Record of sequencing the whole genome in 4 hours. So this is like the ultra rapid sequencing. So this is going to be the future of genetics. So normally in second generation, that is next generation sequencing, what we do, whole exome sequencing, is done by something called a short read sequencing, wherein the DNA is chopped up and then again it is assembled. So you have something called sequence gaps. So this is called the short read sequencing. So this can sometimes miss some sequence data leads, which can lead to missing a few variants, pathogenic variants. So this concept again is improvised with this new technology, that is third generation sequencing, that with long read sequences. Here there's no technique wherein the missing gap of sequence data can be missed. So this is more superior than short read sequencing. So I was talking about omics sequence. So this is called multi-omics or pan-omics or integrated omics. So this concept is basically uniting various type of investigations. For example, if we have if we take metachromatic leukodystrophy as a disease, so if you have an ARSA gene which is deleterious and pathogenic, so that would be your genomics. But at the same time, you would like to prove it biochemically by doing aryl sulfatase enzyme assay. So the aryl sulfatase is also less, so that is also contributing and supporting your diagnosis. That becomes your metabolomics. So doing various metabolic parameters as ancillary tests and supporting to your genomics. So that is going to be the future of medicine. So genomics sometimes can be not integrating with your clinical situation sometimes. So you have to unite with proteomics, metabolomics. So there are a few instances wherein a genetic mutation will cause a problem with the protein. So if you functionally see the aspect of protein, whether it's functional or not in functional studies, in silico studies, so that is going to be your proteomics. So uniting the whole concept of genetics, metabolic, and also protein studies, this is the concept of multi-omics or pan-omics or integrated omics. So this is going to be the future of neurometabolic disorders and IMs as well. So what is the situation of newborn screening in the world as well as India? If you see, these are the countries wherein the newborn screening is done. So these gray countries are actually, there's no newborn screening program. And if you see dark blue and light blue are the ones which have a very good newborn coverage, that is newborn screening is done. So if you see Australia, North America, Russia, a few Asian countries have, and United Kingdom and a lot of European countries have a good, robust newborn screening program. And after that, you have South America and few more countries. If you see India, it's the newborn coverage is extremely low. So in India, parts of Africa, newborn screening is not a universal program because of financial constraints and also population constraints. So I think in future, it's going to be a universal newborn screening program is going to come up. And even in the newborn screening program, each country has a different set of diseases which they screen for. And newborn screening not only includes metabolic disorders, but also hemoglobinopathies and other endocrine disorders, and also a few genetic disorders like spinal muscular atrophy. So the new concept. So now in the next few years, the newborn screening system is going to be outdated because we have something called a universal newborn sequencing. If you see the concept behind this, newborn screening actually looks for around 70 to 100 disorders, which are metabolic disorders where you can find metabolites in GCMS, TMS. And it is going to miss a lot of conditions. For example, the vitamin deficiency, vitamin responsive epilepsies, few mitochondrial disorders, and CDGs, congenital disorders of glycosylation. These are not going to be showing up on newborn screening. And even NKH, that is glycine encephalopathy, is not going to be usually shown on GCMS, TMS. So all these conditions are going to be missed. But if we have a universal newborn sequencing that you basically do whole exome sequencing or whole genome sequencing in every newborn, that is going to predict a lot of diseases early on. And the next part to this is basically prenatal carrier testing. Prenatal carrier testing is basically even before the baby is born, you're screening both the parents. And especially if the parents have history of any metabolic disorder or the parents are consanguineous, you can offer this test of prenatal screening test. So they'll screen for almost 2,500 genes, which are known to be autosomal recessive inheritance. And we can also do whole exome sequencing for both the parents. That can predict any inborn errors which are autosomal recessive. So this concept is going to come soon in various countries. So there was a study already done. So newborn rapid whole exome sequencing, whole genome sequencing was done for almost 388 disorders, and the sensitivity and specificity were extremely high. So this has good robust data as well, and it's going to be introduced in a few developing countries and maybe surely in India as well. So what is the update of IEMs in 2024 in India? So as well as the world. So now that we have rapid whole genome sequencing, the entire treatment approach is changed. So back then we used to focus more on the baseline metabolic workup and then do GCMS, TMS, and then send whole exome sequencing. Now we have whole genome sequencing. The reports of that, the turnaround time is somewhere between 1 to 10 days, depending on which country you are. So this is a big game changer. So even if whole genome is not sequenced, you can actually go for whole exome sequencing that can cut down time. And the concept of multi-omics also has changed. So back then, if you see 1900s to 2024, a lot of things have changed in IEMs. The concept has changed. We have more understanding of IEMs, and we have more and more diseases being identified now. So in 2015, we had around 300 to 400 disorders, which were definitely genetic, which cause metabolic disorders. At the end of 2020, the number rose up to 1,000 IEMs that we definitely know that this gene causes this IEM. And now in 2024, we have around 1,300 disorders, which are well known. And there's a hypothesis, and there's actually a study which said that with this current pace of genetics, we are identifying every genetic disease every day. I mean, one new disease every day. So this is all because of increased availability of whole exome sequencing, whole genome sequencing. And the concept of multi-omics also have increased understanding of our the biochemistry of the gene and then the proteins and also the evidence of that. And with the evidence of with the availability of genetic tests and a lot of neuroradiological signatures have been pathognomonic. For example, we used to have a lot of radiological signs which were not specific for this disorder. Now we have specific signs for specific gene-related metabolic disorder. There's the concept of genotype and radiological phenotypic correlation has also come, and which is going to be very extremely important. So even if you take whole exome sequencing takes around 10 days in India. And if you take whole genome sequencing takes around like 1 week in other countries. So radiology is something very important. So MRI can be done on the same day, and the radiological pattern can be identified, and that can actually guide your management. And this is also extremely important. Why we have more understanding of IEMs in 2024, because we have back in 1950s there was no this subspecialty of pediatric never existed. Then came pediatrics, and then we have pediatric subspecialties, especially pediatric neurology has evolved. Then pediatric neurogeneticists have come up. Then we have neonatal neurology. Then you have pediatric metabolic diseases specialists. And you have pediatric neuroradiologists also, who specifically look at metabolic disorders in pediatrics, that to only brain disorders. And you have metabolic molecular geneticists. And you also have fetal medicine, because a lot of inborn errors of metabolism and metabolic disorders have some sort of antenatal features. For example, if you see Zellweger's has some feature, you have multiple carboxylase deficiency has some features. Few of them have renal cysts, few of them have subependymal cysts, few of them have antenatal hiccups, like NKH can have antenatal hiccups, and specific few conditions will have corpus callosum thinning. For example, NKH also has corpus callosum thinning, which can be identified antenatally. So the collaboration of genotype, radiological phenotype has also been evolved in fetal medicine as well. And as I said, fetal radiology, and even we have specific nutritionists, which they are particularly concerned with the metabolic disorders. Like a lot of metabolic disorders have specific diet and nutrition. So we have specialists who look after only IEMs. So coming to the epidemics, I'll not go into the details, but the incidence has come up almost to 1 in 800 to 2,500. This was like 3 years back, and now even with the exome sequencing, we are finding more and more diseases. The incidence is much more higher. So these are the various disorders. I mean, I will not go into the details of each metabolic disorder, but we'll look into the approach of these disorders. So these are the various disorders according to one study. Again, the incidence of various disorders is different in different countries. So coming to the classification, so this is the latest classification which is proposed in 2023. So this is a little complex to remember, but it won't miss any disorder. So this classification is basically the disorders of intermediary metabolism. So this includes your amino acid, fatty acid, carbohydrate metabolism disorders. So all of your major inborn errors of metabolism will come into this category. That is disorders of intermediary metabolism, including, so basically carbohydrate, protein, carbohydrates, and mitochondria also comes under this. So in disorders of biosynthesis and breakdown of complex molecules, here you have your large molecule disorders, that is lysosomal storage disorders. Here you have various types of disorders we'll discuss in the next slide. Apart from this, we tend to miss these disorders because we never consider purine metabolism or pyrimidine metabolism disorders as one of the IEMs. So this classification actually includes everything. So if you see Lesch-Nyhan syndrome is one metabolism disorder, which is in purine and pyrimidine metabolism, which is also an inborn error. And we have various peroxisomal disorders, like, Zellweger's disorder, and there's something called neonatal adrenoleukodystrophy and RCPD. These are all various peroxisomal disorders, and also Repsom's disease is also one peroxisomal disorder. And you have steroid metabolism disorder and steroid metabolism disorders like Smith-Lembi-Opitz and glycosylation. This is a big entity which is rapidly expanding, which is called CDG, that is congenital disorders of glycosylation. So all these are usually missed in the classification of IEM, so that's why they made this new classification. And a lot of them are not even aware of this entity of disorders of neurotransmitter metabolism. It's also a part of IEM. So you have various metabolic disorders like glycine and serine disorders, and taurine related disorders, and GABA metabolism disorders, and other metabolites which can have sulfite oxidase, that is molybdenum cofactor deficiency and sulfite oxidase deficiencies. So these are also very important because some of them have actually specific precision treatment. The lysosomal storage disorders, as we thought, We have mucopolysaccharidosis is very clinically important because one of the commonest ones, Hurler, Hunter, Sanfilippo, Morque, Moritolami, Sly, and there's a new one which is called Natovic syndrome. So these are named after members also. So 1, 2, 3, 4, and 8. Sphingolipidosis, we have GM1, GM2. GM1, GM2, you have two types, that is type 1 and type 2. Then you have Fabry, Barber, Cautious, Niemann-Pick's, Krabbe, and MLD. You have to remember all the enzymes and all the typical patterns of involvement, which usually GM1, GM2 will have CNS involvement and hepatosplenomegaly. Fabry, we all know that you have renal involvement, you have cardiac involvement, you have angiokeratomas. And cautious, you have hepatosplenomegaly. It depends on which type of cautious, type 1, 2, and it depends on neuronopathic or non-neuronopathic. Niemann-Pick's is again of 3 types. It can have neurological involvement and also hepatosplenomegaly. Krabbe usually has CNS involvement, irritable child presenting in infancy with characteristic MRI findings. MLD usually has onset within 2 years of age, which has specific findings on MRI. There is another entity called oligosaccharidosis, that is, you have galactosialidosis and fucosidosis and mannosidosis. In this group, fucosidosis is common because they have specific neurological findings of different findings. So you have findings of mucopolysaccharidosis and also other features. So another one is mucolipidosis. So mucolipidosis patients are commonly misdiagnosed as MPS because they look very similar because they have a lot of dysmorphism similar to MPS. So this is the overview of lysosomal storage disorders. I won't be going into the deep, but you have to remember that these are all intricately related, and you have to remember the enzymes as well. So the next group is disorders of carbohydrate metabolism. In that, you have carbohydrate intolerance and GSDs. And protein metabolism, you have amino acidopathies, urea cycle disorders, organic acidemias. On the right, so this is another sort of classification which is simple to remember. So there could be a problem in the carbohydrate, protein, or others. In others, you have lysosomal storage disorder, fatty acid oxidation disorders, mitochondrial disorders, and peroxisomal disorders. Okay. So what is more important among all the classifications is this classification. You have to know this in detail. So overall, inborn errors of metabolism are divided into 2 categories, that is large molecule disorders and small molecule disorders. Large molecule disorders are also known as macromolecular disorders, and small molecules are called micromolecular disorders. In large molecule disorders, you have lysosomal storage disorders and peroxisomal disorders. So usually remember, these are large complex molecules depositing inside the cell because of this, they have a lot of organomegaly. So if you remember, lysosomes, the organs where lysosomes and peroxisomes are highly concentrated, so those organs are usually involved. So you have hepatosplenomegaly, you have deposition in the bones, skin, cartilages, ligaments. So you have a lot of dysmorphism because the soft tissue is involved. You have a lot of organomegaly, and some can involve CNS and some may not involve CNS. And usually these deposition takes long time. So that's why large molecule disorders usually present later. So again, there are exceptions for that, but in the general rule is large molecule disorders usually present late. And they can present with spasticity if the brain is involved. Whereas small molecule disorders are extremely important in neonatal age group, because in this you have small molecules like urea cycle disorders, amino acids, organic acids. All these are small molecule disorders, and fatty acid oxidation disorders and carbohydrate metabolism disorders are also small molecule. And these present very early. So remember, so these are all the types. So these present with acute encephalopathy, sepsis-like presentation. So these are all the ones which are often missed in newborn. So they can have various presentations like, encephalopathy, lethargy, sepsis-like condition, unexplained encephalopathy, seizures. And sometimes these are often confused with sepsis also. So small molecule disorders often present early within the neonatal period or within infancy. So 95% of all the small molecule disorders present within 1 year of life. Another hallmark of this feature is when these disorders have presentation during acute febrile illness. For example, you have an underlying small molecule disorder, and there's an acute febrile illness which causes metabolic decompensation. And suddenly, during that febrile illness, you'll have exaggeration of this disease. So they'll present with acute encephalopathy. So recurrent encephalopathies or recurrent distress or recurrent seizures presenting in an infant, we have to think about small molecule disorders. All right. So there's another classification which is also similar to this large molecule and small molecule. This is called Souther-Brace classification. So here there are three types of disorders we'll discuss in this next slide. So Southern classification says that there are three types. That is, first is intoxication disorders. As we discussed in the first slide, Garrott's hypothesis, if there is an enzyme which is deficient, so the precursor, the proximal substrate will deposit in the body, and that will also be converted to other compounds, and that will deposit in the body. For example, if you have phenylketonuria, if you have phenylketonuria hydroxylase deficiency, so you have phenylalanine being deposited, and phenylalanine will convert into other components, and both of them actually phenyllactate. All of them cause damage. So that is called intoxication disorder. That is a typical example. It's all again small molecule disorder. Second thing is energy metabolism disorder. So here what happens, because of the enzyme deficiency, the product is not formed, and the product is usually glucose. So you'll have hypoglycemia or glucose deficiency, or particular metabolism energy is deprived. So the classical example for this is glycogen storage disorders and carbohydrate metabolism disorders, and also mitochondrial disorders. And the third would be storage disorders, wherein this is the example of large molecule disorders, wherein enzyme deficiency causes deposition, slow deposition. For example, if you see Gaucher's disease, there's glucocerebrosidase deficiency. They have the ceramide being deposited for a long time, then present with organ decay. So these are the classical examples of inborn errors of metabolism. So again, you have to know like which type of inborn errors of metabolism present in which type of which age group. So most of the small molecules present within neonatal period to early infancy, whereas large molecule disorders can present somewhere after infancy, even till adolescence. So lysosomal storage disorders are a typical example of large molecule. They can present any time after 1 year. And there are exceptions for these. So exceptions include, there is something called intermediate or intermediary type of metabolic disorders. They don't belong to small, then they don't belong to large. The example for that is mitochondrial disorder, peroxisomal disorders, and CDG. So these three entities can present at any time. So they can break both the rules. Mitochondrial disorders can present all the way from neonate, infancy, even up to adulthood. So mitochondrial disorders presenting in infancy is lay-like phenotype. You have PDH, PCH presenting in infancy, neonatal age group, and MELAS and MERV. All these can present somewhere, KNCS disease, even in adulthood. So that is a typical example of, dual presentations. So I'll not go into the details of lab patterns because Dr. Arvind has discussed it in detail with a lot of case scenarios. But remember, the combination of these findings are extremely important in deciding what needs to be done in the immediate ICU management. So you need to get blood gas analysis, then serum ammonia, then you have to get urine ketone bodies and sugars, and also critical sample also includes free fatty acids. So all these are very important. They must be done in all the cases. And also remember, the sample needs to be taken appropriately, because excessively squeezed sample can have falsely elevated levels of ammonia as well as lactate. And if the sample has been kept for a long time before sending to the lab, you also have false elevation of ammonia and also lactate. So that is extremely important here again. And also remember, when the sample is taken, these are all critical samplings. So when the child is actually encephalopathic, you need to take the sample at that time. For example, if you have some small molecule disorders and you have given IV fluid and you have taken the sample for metabolic workup after 1 day, so there might be a very good chance that that the metabolic crisis has resolved and you may not get accurate answers. So these are critical samples. The samples need to be taken as early as possible before installing any treatment, and they need to be taken during the acute decompensation phase. So overall, if you see, organic acidemias will have acidosis and hyperammonemia and hypoglycemia. Amino acidopathies also have hyperammonemia sometimes, and they can have acidosis. And remember, hypoglycemia can be there in all of these, like organic acidemias, carbohydrate metabolism disorders, amino acidopathies, and also fatty acid oxidation disorders. If you see, hypoglycemia is very, very severe, like, less than 20 or 30, or refractory hypoglycemia seen disorders of carbohydrate metabolism and fatty acid oxidation disorders. And remember one thing, ketones can be positive in any condition which causes hypoglycemia, except for fatty acid oxidation disorders. So basically, that's why it's called hypoketotic condition. So when you have hypoglycemia, so the ketones are produced for alternative energy, but the exception is that the ketones are not able to form because there's a enzyme deficiency on that pathway as well. So fatty acid oxidation disorders, you have typically low sugar and low ketone. So that is one thing. Also remember, hyperinsulinemia can also have normal ketones or low ketones. When it comes to lactic acid, again, lactic acid also needs a very important sampling. So ideally, the lactic acid sample needs, see, ammonia and lactic acid needs to be transported as soon as possible, and they're transported in the ice packs because hemolysis doesn't happen. So hemolysis or squeeze sample will have falsely elevated lactate. And lactates are extremely high or double or triple, or even sometimes 5 times the normal value in mitochondrial disorders. Okay, so I won't go into the deep patterns of these IEMs. So I think they're described in the previous lecture. So let's look at few clinical handles. Before that, a family history is very important. I always focus on family history. Ethnicity, sometimes there are a lot of ethnic groups wherein this type of IEMs are common. We'll discuss that. And physical examination also is important to look at few clinical handles. So here, ethnicity, these are the disorders which are common in Ashkenazi Jews, that is Gaucher's, Tay-Sachs, Canavan, maple syrup urine disease, mucolipidosis type 1, Niemann-Pick's type 1. This is a particular group in Jewish communities, it's called Ashkenazi Jews, are very common. In India, megalencephalic leukodystrophy with cysts, that is MLCC, is common in Agarwal community, and PCAN is also common in a few communities. And LGMD is also common in, though it's not IEM, just ethnicity is important in any genetic disorder. So remember this rule that almost 95% of all the inborn errors of metabolism are autosomal recessive. So only remember the exceptions. That is, X-linked recessive disorders are Hurler syndrome, Fabry's disease, Lesch-Nyhan syndrome, G6PD, Menkes disease, and adrenal leukodystrophy. These are X-linked recessive disorders, though present exclusively in males. And autosomal dominant is porphyrias. But rest everything, that is almost 95 to 96% of them are autosomal recessive. So there will be history of consanguinity, some in most cases. So this genetic history is very important. And clinical handles, we'll discuss each. These are various clinical handles. So what is clinical handle? So in each patient, we have various clinical findings which are positive. For example, the child has dysmorphism, microcephaly, hyperammonemia. I mean, if you start chasing hyperammonemia, there could be potentially n number of differentials. So that is not a good clinical handle. But for example, if you have cherry red spot, so you have very less number of differential diagnoses, you can reach the diagnosis very fastly. So that is clinical handle. The clinical finding, which is most important, that will lead very rapidly to your diagnosis. So always learn to identify clinical handles and do not chase any clinical sign specifically. I mean, try to identify the best clinical handle and then chase that specifically. For example, even corneal clouding has very high yield when you actually chase it. Corneal clouding is seen in less than 10 conditions. So if you actually look for all of them, you'll find the diagnosis. When cataracts, facial dysmorphism, cutaneous markers, neonatal cholestasis, encephalopathy, we'll discuss this in the next slides. And dietary triggers, always ask that, specific encephalopathy or decomposition happened after milk introduction. For example, if the child was breastfed exclusively 6 months, the encephalopathy happened somewhere at 6 to 7 months. Start thinking that complementary feed has triggered this. So mostly it's not milk. So milk intolerance will come in the first month of life because, for example, galactosemia, the mother's milk is intolerant. So you'll have galactitol formation, and within first month you'll have presentation. And complementary feedings are usually started at 6 months, 7 months. So introduction of that complementary feeding, for example, fructose 1,6-bisphosphonate, fructosemia. Fruit was introduced to the child, and again the child had hypoglycemia. So that is for fruits, high fructose drinks like Coca-Cola, and high protein meal will trigger organic acidemias and other protein metabolism disorders like amino acidopathies. So you have to ask for that. And fasting hypoglycemia is very important in glycogen storage disorders. For example, overnight, the night meal was somewhere at 8 o'clock until the morning. There was no meal. There was a long gap of feed. So this fasting hypoglycemia will give you clues for glycogen storage disorders. And biochemical handle, as I said, these are all biochemical handles. But again, clinical handles are more important because biochemical handles can be pretty non-specific. So if you see on the left side, this is oil drop cataract, which is typically seen in galactosemia. This is sunflower cataract, which is seen in Wilson's disease. And this is the brushbill spot, although not an inborn metabolism, a common finding in Down syndrome. What is this condition wherein you have this kinked hair? This is Menkes kinky hair syndrome. You also have frontal balding, and you also have pallor, and you have seizures in this child. On the right, if you see, this is a blonde baby syndrome. So blonde baby is a very good differential and very good clinical panel. There are very few conditions which are actually called blonde. So phenylketonuria will be a starting differential diagnosis, followed by some immunodeficiency disorders like gristly, Chediak-Higashi, Norman-Skipper, etc. So this is the typical gristly syndrome, that is silvery gray hair syndrome. They have immunodeficiency and also silvery gray hair syndrome, and sometimes they can have neurological involvement in the form of CNS, HLH, and seizures. So any newborn who has rash, always rule out biotinase deficiency. It's a very important finding. And if you have ichthyosis, think of multiple sulfatase deficiency. So dysmorphism, which is similar to Down syndrome, we think about Zellweger syndrome. So Zellweger syndrome is a peroxisomal disorder, though typically not a small molecule disorder, can present in newborn period because, as I said, mitochondrial disorders, peroxisomal disorders can go on either side. And Zellweger syndrome is a typical example of peroxisomal disorders. They have dysmorphism, they have organomegaly, they're described to have Down-like facies. So this is a case of Zellweger syndrome. And what you see in this child, you see there's a lot of coarseness. This is the typical example of coarse facies. You can see the nose, you have the folds of the skin being very tough. And this is the typical example of a coarse facies, so typically seen in mucopolysaccharidosis, mucolipidosis, and fucosidosis. On the left also, you see coarse facies. Coarse facies can also be seen in congenital hypothyroidism. So what you see in this picture, there is corneal clouding. Corneal clouding has again very less number of differential diagnoses. The main differential diagnosis would be your mucopolysaccharidosis and mucolipidosis. So even amongst the mucopolysaccharidosis, some of them do not have corneal clouding. So if you see Hunter's disease, does not have corneal clouding, but Ehlers will have corneal clouding. Morquio will have corneal clouding. Morto-Lama will have corneal clouding. So this is a typical dysmorphism seen in mucopolysaccharidosis. The whole complex is called dysostosis multiplex. So that's why you need to give X-rays and skeletal surveys to look for these findings. You see, they have a lot of spinal deformities like kyphosis, scoliosis, pectus carinatum, lordosis. They have a lot of bony deformities, frontal pausing. And you have various X-ray findings also. Like, for example, you have bulleting of metacarpals, you have J-shaped sella, you have skull thickening, you have something called O-shaped ribs, that's called O-ring of ribs, and also beaking of vertebrae. So this whole complex is called dysostosis multiplex, a very characteristic feature of MPS. And always look for organomegaly. So this is another child who had glycogen storage disorder with organomegaly. There's a massive liver, you think of GSDs. And in the examination, always don't forget to take height, because whenever you have short stature, because most of the inborn errors of metabolism will have failure to thrive and short stature, but few of them have tall stature. So this child, this is the younger sibling of the child who's quite short, but the other sibling is like extremely tall. So tall stature, think of Marfan's disease, but inborn errors of metabolism, think of hereditary homocysteine. So they have similar type of features of Marfan's. That's why they're called Marfanoid picture, because they also have subluxation of lens. So this is a peculiar finding seen in a metabolic disorder, which is called cornelia verticillata, which is a feature of Fabry's disease. And this is a hallmark feature of Fabry's disease, which is called angiokeratomas. So these are basically cutaneous angiomas. So combination of this will actually give you a clue that you're dealing with Fabry's disease. So this is inverted nipples and abnormal fat distribution in the lumbar fossa. This is a hallmark feature of CDG, that is congenital disorders of glycosylation. And ambiguous genitalia, think of CAH, that is congenital adrenal hyperplasia, will also be usually screened in newborn screening. So these are extensive mongoloid spots. So normally you have one or two mongoloid spots which are big, which are there in the lumbar fossa or in the back. So that is a usual spot. But if you have extensive or a large mongoloid spot which is not going over time, start thinking about disorders like GM1 and GM2 gangliosidosis. They also have umbilical hernias. Coming to 2D echo is a very important investigation in few metabolic disorders. Like few metabolic disorders are known to have cardiomyopathy, especially Pompe's disease and fatty acid oxidation disorders. And sometimes MPS can also have cardiomyopathy, dilated cardiomyopathy. Another finding, that is a urine odor, not very commonly seen in clinical practice, but different various kinds of urine odor can also give you clues for IEMs. Like the common one is maple syrup. Maple syrup is like almost like a caramel or burnt sugar smell, which is seen in MSUD. Sweaty feet can be seen in isovaleric acidemia or glutaric aciduria type 2. Boiled cabbage is tyrosine 1. Rancid butter is tyrosine 1. An acid-like smell is be seen in MMA, and cat urine is seen in NCD. So cherry red spot, you have to remember this. Cherry red spot can be seen uh, because of the deposition of this complex lipid molecules in all over the retina, except for the macula densa. So it can be seen in Niemann-Pick's GM1, Tay-Sachs, Sandoff, MND, Fabers, mucolipidosis, sialidosis. So these are all the workup we have to do in IEMs. Do the routine workup. Always look for associated features. I mean, CBC electrolytes must be done to rule out causes of seizure. Then start with blood gas analysis, urine pH, LFT, KFT. To look for few inborn errors will have liver involvement. Glucose, that is ketone bodies, ammonia, lactate. CPK can be done because a few metabolic disorders like fatty acid oxidation disorders and metabolic mitochondrial disorders can have myositis and myopathy. So CPK can be elevated. Urinary gag in MPS and bone marrow biopsy to rule out any bone marrow involvement, like the Gaucher's disease and Niemann-Pick's can have bone marrow. So then you followed by GCMS TMS, that is formally done these days, and then followed by genetic disorder, genetic testing, which we have discussed. So we'll just go into the options of genetic test we have currently, because in India, in most countries now, the GCMS TMS is the cost is around like 4,000 to 5,000, but the genetic testing, the cost has rapidly come down. So rather than do a non-specific test, we can directly go for genetics as well. But we need to be very careful. Sometimes we have variants of uncertain significance. We have to classify them according to the clinical features. So options in next-gen sequence, you have rapid whole genome sequencing, you have rapid whole exome, you have normal whole exome sequencing, clinical exome sequencing, and panel. So whatever is available in your country and state, you can do that. Expensive. So a lot of people say NGS is expensive, but I say it's more cost-effective because instead of avoiding all the other ancillary tests, you can do a genetic test which will give you answers, which will always give you accurate answers rather than GCMS, TMS. And there are no technical challenges. If you see biochemical parameters like ammonia, lactate, GCMS, TMS need to be taken at specific time of, the critical sample needs to be taken when the child is encephalopathic. Sometimes there are technical challenges that, the person has not been there. And so all the technical challenges are usually not there with genetic testing. Aids in testing the family members, especially if you find a disease which is autosomal recessive, there's very likelihood that the parents are carriers. So that will also help you in counseling the next conception. The only disadvantage is variance of uncertain significance. So to avoid this variance of uncertain significance, you have to have a good clinical picture, your clinical hypothesis, and your ancillary test should help in this. And the ancillary test should be your MRI, etc., and also GCMS TMS will help in this. And complete clinical history, as I said, every detail matters because in genetics, even a small detail like microcephaly, the head circumference, if not mentioned, your diagnosis can be missed. Because during the process of whole genome sequencing or next generation sequencing, it is very difficult to differentiate a pathogenic variant from polymorphism. Polymorphism is a gene variation or a variant which can be present in normal individuals. So if you don't give a critical clinical history, we don't know whether it is a polymorphism or a variant. So that the gene can be particularly missed and you don't have any answers on the genetic test. Then you have another test which is called gas chromatography. We do it routinely. So it is less expensive than the genetics, but faster turnaround time can be seen with traditional, or you have the report within 24 to 48 hours. But the diagnosis is not specific because you have these metabolites being elevated in various conditions. For example, non-specific elevation of 5-hydroxytryptamine can be seen in phenylalanine metabolism and also tyrosinemia in various disorders. And these metabolites can also be elevated in liver dysfunction. So most of the metabolic disorders can have transient liver dysfunction. Then you have elevation of all these enzymes, all these parameters, and then will give you false diagnosis of these metabolic disorders. For example, we had a child with elevation of 5-hydroxytryptamine, 4 times elevation, and the GCMS TMS report came as tyrosinemia. And we thought that it was tyrosinemia because the child had liver involvement, and we were actually prepared for the formula feed, special diet, and also liver transplant. But the genetics came back saying they found a pathogenic variant in fructose 1,6-bisphosphatase deficiency. So the whole treatment is different. With fructose 1,6-bisphosphatase deficiency, the treatment is just cornstarch. Don't need a transplant. So sometimes, GCMS, TMS can be tricky. You need to have a lot of things in mind. You have to send the sample in the correct time, correct method, and then interpret very correctly. sensitivity depends on these factors: the timing of collection method, and transport. It is not a comprehensive test. It can miss a lot of conditions, and it needs further confirmation, because it's not one single test which can finally give you all the answers. And basic management of IEMs: stabilize the child, give management, that is symptomatic management, always correcting the fluid. Dehydration itself will decrease the symptoms of a lot of metabolic disorders, because whatever the toxic metabolite is, it's basically diluting it. So dilution of that particular toxic metabolite also helps in treatment. So stabilize the patient, correct the dyslipidemia, and always give high dextrose to patients, because a lot of metabolic decomposition happen when there's no low glucose. So low glucose will actually increase breakdown of fat. Then you have ketosis. So most conditions giving high dextrose actually as boluses can actually prevent catabolism and improve IEMs. And you should avoid RL and hypotonic fluids. And in specific conditions, for example, benzoate can be given if there is hyperammonemia, and nitisinone can be given in tyrosinemia 1. And in some conditions wherein you have refractory acidosis, you can go for hemodialysis or plasma exchange. And metabolic cocktail can be started. So metabolic cocktail can be, mitochondrial cocktail, that is coenzyme Q plus carnitine, and even vitamins like biotin, thiamine, pyridoxine can be added as a metabolic cocktail. So this is the treatment approaches. In the various imbalances of metabolism, you can actually replace the enzyme, that is called enzyme replacement. For example, Gaucher's disease, Niemann-Pick's disease, MPS will have, there are almost like 10 to 15 disorders which have enzyme replacement currently available. So the enzyme is deficient, you can replace it. And second thing, if there's cofactor deficiency, you can give a cofactor replacement. For example, coenzyme Q is a cofactor in mitochondrial disorder, so you can supplement it externally. But the ultimate treatment, the complete cure of the disease, can happen with gene therapy. So gene therapy is also available in few metabolic disorders, and recently in 2023, even metachromatic leukodystrophy has been approved for gene therapy. It's called atidasogene. So these are the various strategies in treating. So coming to neuroradiological signatures, this is going to be a little extensive. I'll just take 10-15 minutes to cover this. So whenever you have a clinical picture, try to see the biochemical parameters and create a hypothesis, send GCMS, TMS, and also do neuroradiology. That is MRI is extremely important, because each metabolic disorder will have a specific neurological signature. So MRI needs to be done as early as possible, because few diffusion restriction findings are usually seen in the first 3 days, and sometimes can be seen with 7 days. When the entire metabolic decomposition goes away and you think that the patient is sick and I can't shift the patient to the MRI, and you do an MRI after 7 days, sometimes the MRI can be normal, because the acute changes during the the critical stage, you have diffusion restriction findings, which are often missed when done late. So these are various findings. So this is a normal MR spectrum. So always remember, in metabolic disorders, always add MR spectroscopy, because you will get a clue that what toxic metabolic is getting deposited. So this is a normal MR spectroscopy wherein you have these peaks. So this is called the Hunter's angle or Hunter's line, wherein you have choline, creatine, and Na. So choline will be the smallest, and creatine will be slightly more than choline, and Na will be almost double like creatine. So this is called the Hunter's line or Hunter's angle. So this is a normal picture. So in various conditions, you have different features. So here in this condition, if you see in the left, if you see MRI, there is hyperintensity in the lenticular nucleus. So this is a typical feature of mitochondrial disorder, lay-like presentation. On the right side, there is a negative lactate peak. So when you have this kind of picture with negative lactate peak, you are pretty much sure that you're dealing with a mitochondrial disease. And here on the left side, if you see that there is diffusion restriction in the posterior limb of internal capsule, thalamus, and also posterior fibers of white matter, and also cerebellum, and even midbrain. So this is a very characteristic feature of MSUD, maple syrup urine disease. So this is called myelin splitting edema. So in the MR spectroscopy, what happens in maple syrup, basically you have branch chain amino acid deficiency. So few of the branch chain amino acids will be elevated. So the same thing is seen in the MR spectrum. So there's a peak of branch chain amino acids. So on the left side in the imaging, you see what is a feature which is seen here. So there's diffuse white matter involvement in the frontal as well as posterior region. So this is a typical feature of MLD. So MLD will have decreased Na peak. So here, what else do you see? Here you see there is increased glycine peak. So increased glycine peak is seen in NKH, that is non-ketotic hyperglycinemia or glycine encephalopathy. Sometimes these features will be clinically correlated, because remember, NKH can present antenatally with antenatal seizures and postnatally neonatal hiccups. Hiccups can also be a presentation of NKH. So here in MRI, you see there is a lot of atrophy of the Sylvian fissure area is very widened. So this is called the back wing appearance of the Sylvian fissure. Along with it, in the second picture, you see there is subdural hygroma. So there is atrophy, subdural hygroma with deep nuclear changes. There is the lenticular nucleus and thalamus hyperintense. This is a very characteristic feature of glutaric aciduria. And this picture, this patient had stroke-like episode with the occipital and parietal region being involved, with showing diffusion restriction. So this is a characteristic feature seen in MELAS. So in this picture, this child has presented in 6 months of age with extreme irritability. This child had microcephaly. On the MRI, there are diffuse white matter changes. Okay, along with optic nerve thickening. So this is one of the features of Krabbe's disease, and the child will be extremely irritable. What do you see here? This is a case of mucopolysaccharidosis with diffuse white matter changes, and this is the J-shaped cella, and there is frontal bossing. There's platyspondyle also. So this is in case of MPS. So what is this? This is the typical posterior periventricular hyperintensities, which is seen in adrenoleukodystrophy, and they also have contrast enhancement, and typically splenium of the corpus callosum is involved. So in this, you have decrease in NAP. So this is adrenoleukodystrophy. So the various conditions again. So what is this syndrome? So this is a very tough one. So this child had dysmorphism at the age of 2 months. We got an MRI. You see, this is a very characteristic feature. The black arrows actually show this is perisylvian polymicrogyria. So you see around the Sylvian fissure, there are multiple gyrations. So these gyrations are normally seen in, not normally seen in a baby. So this is called perisylvian polymicrogyria, a lot of gyrations. So you also have peri or subependymal cysts here. So these are all telltale signs of Zellweger syndrome. So in Zellweger syndrome, we can also have decrease in AAP. So this is another classic condition wherein you have diffuse white matter changes involving subcortical blue fibers, and the entire white matter is involved. In the MR spectroscopy, you're having NAAP. So this is a very classical feature of Canavan disease. So here, there are various conditions again here. So you remember, this child again has diffuse involvement of white matter disorder. So this is a very specific, non-specific white matter disorder. This can be seen in various leukodystrophies. So this is again a mitochondrial disorder. So this picture can also be seen in NKH. So here you have thinning of corpus callosum and also involvement of lenticular nucleus. So another disorder, which can present late during infancy or sometimes even in adolescence. So here the child is present with intellectual disability and autistic features. On the MRI, there is negative creatine peak. So this is creatine transporter disorder, which is a treatable condition. So whenever you have inborn of metabolism with cerebellar atrophy, think of CDG, that is congenital disorders of glycosylation. So to summarize, so clinical handles, including family history, pedigree, consanguinity, prenatal and postnatal history, prenatal history of oligohydramnios, prenatal seizures, prenatal increased movements, postnatal history of seizures, development, and the clinical handles together include your clinical handle, along with rational investigations like skeletal survey for MPS, nerve condition studies for MLD, 2D echo for Pompe's, ultrasound abdomen for other malformations, fundus examination for lysosomal storage disorder like cherry red spot, and EEG for few epileptic conditions like Zellweger's can present with a lot of abnormal discharges, and even pyruvate metabolism disorders, pyridoxine dependency. All of them can present with a lot of seizures and epileptic encephalopathies. And next is neuroimaging, because we know that there is a specific neurological signature for various neurometabolic disorders. Get an MRI brain with MR spectroscopy and order a spine MRI, because some mitochondrial disorders can also involve spine, like LSPL. And contrast also is important because few metabolic and leukoencephalopathies will have contrast enhancement, like adrenoleukodystrophy has contrast enhancement of the leukodystrophy changes. And CT brain also can be helpful in sometimes in seeing calcifications. So calcifications can be seen in a lot of conditions when specifically you order for CT brain. And even in Krabbe also you can do a CT because of the thalamic changes you see in. And comprehensive metabolic testing, including GCMS, TMS, enzyme assays, and specific urine substrate assays like urinary gags, etc., can be done, and which can be followed by genomics. So they have a complete picture. When you have metabolomics plus genomics, the concept of multi-omics came again. So all these features together, then you do a genetics, that is whole genome sequencing or rapid whole genome sequencing if there's an emergency, or you can do whole exome sequencing. So whole exome sequencing is pretty good if you're suspecting or if you have a phenotype which is already there. So combine together or put all of them together, then you have a very likelihood of a correct diagnosis. Thank you. Hello. Yeah, I'm coming. 1 second, 1 second. Yeah, you're at the hospital. Okay, so I was, yes, and I was in a lecture.